Private Health Insurance and Managed Healthcare Introduction. Hello everyone, and welcome to today's lecture on private health insurance and managed healthcare. This is Dr. Shankar at the American University of Health Sciences. This is a critical topic for understanding how healthcare financing works in the United States and how it affects both patients and healthcare professionals. Today we'll be exploring a complex but fascinating area of healthcare policy and economics. We'll examine how private insurance evolved, why we need it, how it operates, and the various models of managed care that dominate today's healthcare landscape. In the description, you have references with more information about this topic. Learning objectives. By the end of this lecture, you should be able to first develop a clear picture of uninsured populations in America and understand who they are and why they lack coverage. Second, know the historical perspective of protecting against the uncertainty of healthcare costs and how this evolved into our current system. Third, understand the different types of health insurance and key concepts of the industry, including how insurance principles apply to healthcare. Fourth, investigate trends affecting private health insurance and how the industry continues to evolve. And finally, analyze how prescription drug coverage fits the principles of risk management and why it's become such an important component of health insurance. The paradoxes of health insurance. Before we dive into the specifics, it's important to understand that health insurance creates some interesting paradoxes. On one hand, health insurance leads to improvements in health status and increased standard of living for those who have it. People with insurance access care more readily and face less financial hardship when illness strikes. To truly understand health insurance, we need to grasp two key concepts: the basic principles of insurance and the unique needs of the insurance industry. These foundations will help us understand why health insurance operates differently from other types of insurance and why it's become such a complex system. Origins of health insurance in the United States. Let's start with history. Health insurance in the United States has a fascinating origin story that began as early as 1798, but initially focused on income protection during illness, essentially disability insurance. These early plans didn't actually cover health expenses directly. Instead, they provided coverage only for specified diseases and focused on replacing lost wages. The first real hospital insurance was initiated for Dallas school teachers through a prepaid plan that collected monthly premiums. This innovative approach eventually evolved into the statewide Blue Cross system, which allowed coverage at all participating hospitals. The focus was on partial reimbursement, typically covering about 80% of costs. Medical insurance developed separately through Blue Shield, created by a group of Los Angeles physicians. This plan uniquely developed a model for organizing physicians into large practice groups. Like Blue Cross, it focused on partial reimbursement of medical visits. The California Medical Association formalized this approach in 1939. Interestingly, health insurance gained significant momentum during World War II when employers used it as a benefit to entice new employees during wartime labor shortages. The evolution continued with major medical insurance, comprehensive plans designed to protect against catastrophic illness or injury. Prior coverage had been limited to specific dollar amounts, but major medical insurance provided broader protection. Evolution of reimbursement systems. The process of reimbursement evolved significantly from what we might call the shoebox receipts era. Initially, we had indemnity insurance, where reimbursement went directly to subscribers for 80% of expenses, not to providers. The objective was to protect both patients and healthcare providers from financial loss and bankruptcy. Due to administrative problems with indemnity plans, service benefit plans emerged. Under this system, healthcare providers submitted claims and were reimbursed directly. This allowed for better cost controls through standardization and automation in claims processing. As private insurance evolved, it primarily supported and reinforced existing patterns of health services. However, it also neglected areas that would later be covered by public insurance: prevention, control of communicable diseases, and care for the sickest and neediest patients. Private insurance operated as pass-through indemnity plans, guaranteeing protection against financial loss to providers through fee-for-service payments with no controls on costs, utilization, or quality. Separate coverage of prescription drugs evolved from major medical plans, starting with the Green Shield plan in Ontario in the 1950s. Growth was slow in the U.S. until 1969, when the United Auto Workers Union negotiated for prescription drug coverage through Blue Cross. This negotiation stimulated prescription insurance penetration significantly. The numbers tell a dramatic story. Prescription insurance covered only 12% of all retail prescriptions before 1970, but this grew to more than 76% by 2001. Today, private insurance covers about 42% of prescriptions as of 2023, with 51% covered by public insurance programs like Medicare and Medicaid, and only 10% paid out of pocket. The fundamental purpose of insurance is to help individuals and businesses manage certain types of unanticipated risk. Insurance serves as an integral part of our system of social protection and private compensation. It's designed to reduce pure risk, which becomes an insurable hazard when it meets certain criteria. You might wonder why prescription drugs warrant separate insurance coverage. There are several compelling reasons. First, drug therapy is often preventive in nature, helping to avoid more expensive medical interventions later. Second, drug therapy can be the most cost-effective way to reduce overall healthcare costs. Third, while prescription drugs once seemed inconsistent with traditional risk management principles, this is changing for specific groups. Rising prescription expenditures are shifting as a proportion of income, and unpredictable prescription costs create significant hazards, especially for low-income individuals and the elderly. Let's examine the essential components of group health insurance, starting with patient cost sharing. These mechanisms are designed to control utilization of health services by moving demand from inelastic to elastic, essentially making patients more price-sensitive in their healthcare decisions. There are three main types of cost sharing. Co-payments require patients to pay a specified dollar amount for each service or prescription. Deductibles require out-of-pocket payment until a specified amount is satisfied within a designated time period. Coinsurance requires patients to pay a specified percentage of the cost of service. Group health insurance involves multiple stakeholders with different, sometimes competing goals. Employees want convenient access to healthcare providers, quality services, and reduced out-of-pocket costs. Employers want healthy, satisfied employees while minimizing expenditure on healthcare benefits. Administrators must satisfy employer groups by maintaining adequate networks of healthcare providers while keeping costs within targeted ranges. Healthcare providers generally want removal of third-party payers from the relationship between providers and patients. This creates a fundamental tension. Providers want to maximize reimbursement, while consumers want to maximize health benefits while minimizing personal expenditures. Now let's turn our attention to a critical issue: the uninsured population in America. The uninsured face greatly increased barriers to healthcare utilization, resulting in poorer health and shorter life expectancies. They also face potential financial catastrophe from medical bills. Contrary to what many people expect, the profile of the uninsured doesn't fit the stereotype of poor, disabled, and elderly populations. Budgetary constraints on Medicaid have actually increased the at-risk population, leaving many without insurance or with inadequate care. Medicaid has absorbed many potential uninsured during economic downturns, with coverage for the poor increasing from 11.6% in 2002 to 25.2% in 2023. The current statistics are sobering. 27.6 million Americans lack health insurance on any given day as of 2023. Over 3/4 of those uninsured at a specific point in time have been uninsured for more than 12 months. The number of people receiving coverage from employers has dropped significantly, from 60.4% in 2003 to 49% in 2021. Meanwhile, the percentage of uninsured working people has increased from 18.6% in 2003 to 20% in 2022. The working poor comprise the largest group of adult uninsured, with 81% employed by firms that either don't sponsor health benefits or aren't eligible for their employer's plan. Foreign-born U.S. residents have twice the probability of being uninsured, though they represent only 10% of the uninsured population. Importantly, 79% of the uninsured are American citizens. Young adults face particular challenges, with 31.4% of all young adults aged 19-24 lacking insurance. According to the Kaiser Family Foundation, the reasons for being uninsured are telling. 52% say health insurance is too expensive, 11% are not eligible for their job's health benefits, and 7% say they don't need it. Administration of prescription drug programs. Prescription drug programs operate through specialized systems. Pharmacy benefit managers serve as a carve-out used by insurers to increase efficiency in managing prescription drugs. They essentially function as managed care organizations specifically for prescription costs. Participating pharmacy agreements are contracts between pharmacies and insurers that specify eligibility, services to be provided, reimbursement terms, exclusions, and other provisions to control costs. Reimbursement terms are usually comprised of acquisition cost plus a dispensing fee. Acquisition cost is typically based on average wholesale price, or AWP, less a discount. AWP typically exceeds actual acquisition cost, creating an earned discount, the difference between AWP and what the pharmacy actually pays. To counter variations in actual acquisition cost, third parties have now switched to estimated acquisition cost, calculated as a percentage of AWP. Introduction to managed care. Now let's explore managed care, which has become the dominant form of health insurance in the United States. Managed care is a healthcare delivery system organized to manage cost, utilization, and quality simultaneously. There are 4 primary types of managed care organizations: health maintenance organizations, or HMOs, preferred provider organizations, or PPOs, point of service or POS plans, and exclusive provider organizations, or EPOs. PPOs are by far the most common form of managed care in the United States. What is a managed care organization? A managed care organization, or MCO, is a healthcare provider or a group of medical service providers who offer managed care health plans. These organizations vary in their constitution. Some are made up entirely of physicians, while others combine physicians, hospitals, and other providers. Common types of MCOs include group practices without walls, independent practice associations, management services organizations, and physician practice management companies. What is a managed healthcare plan? Managed healthcare plans are types of health insurance plans that emerged in the latter part of the 20th century. These plans provide health insurance policies to individual members of a group or employer, where the group or employer serves as the plan sponsor. Managed healthcare plans help beneficiaries by securing more favorable rates or discounted medical insurance services from their plan's health provider network. They allow plan sponsors to negotiate reduced rates for their policyholders with hospitals, medical service providers, and physicians by including them in the network. Let's examine each type of managed care organization in detail. Health maintenance organizations, or HMOs, provide employers or groups a way to take care of all their employees' or members' healthcare needs with reduced costs by negotiating with specific doctors, hospitals, and clinics. Employees must use these specific providers for the reduced fees to be provided to their medical insurance plan. HMOs are the most restrictive type of managed care and frequently require members to select a primary care physician from whom a referral is typically required before receiving care from a specialist. HMOs usually only pay for care within the provider network. In an HMO plan, you have the least flexibility but will likely have the easiest claims experience since the network takes care of submitting claims for you. Preferred provider organizations, or PPOs, offer reduced costs to members billed to their health insurance plan. Unlike HMOs, employees or members can choose the physician they want to see instead of being solely restricted to network providers. A member can choose between a network or non-network provider. PPOs allow members more flexibility than HMOs do, which makes them popular. They usually allow members to receive care out of network, but the member must pay more than if they use a network provider. Premiums for PPOs are typically higher than those for HMOs. With a point of service plan, or POS, members can choose their physician from those who have previously agreed to provide services at a discounted fee. In a POS plan, the member uses the chosen physician as a gateway before moving on to a specialist. POS plans offer a middle ground between HMOs and PPOs. Like HMOs, POS plans usually require members to have primary care physicians. Like PPOs, POS plans allow members to go out of network for care, although they must pay more than they would for a network provider. With an exclusive provider organization, or EPO, the employee or member can choose from providers within the network and doesn't have to work with a primary care physician. However, any service taken outside of the network may not be covered at all. EPOs require no primary care physician, allow members to choose any provider in the network, provide no coverage for outside network providers, and offer some flexibility and choice, though typically at higher cost. The managed healthcare plan proposition provides benefits to both plan members and sponsors. Managed healthcare plan members benefit from reduced rates and guaranteed access to healthcare services. Members of the health network benefit from having a steady stream of clients. Plan members have an easier time because when they work with providers in the network, they avoid having to file paperwork since the network members and medical service providers have integrated billing systems. HMO plans make this process the easiest. Let me present a real-world scenario to help illustrate these concepts. Barb et al. Recently graduated from pharmacy school and is considering a job offer from a large pharmacy chain. As part of her benefits package, the company will pay half of the premium for Barb's health insurance coverage. Barb knows this is a good deal. Even if she paid 100% of the premium, the group policy would be much less expensive than a policy she could buy individually. She also knows that if she doesn't elect to participate when she begins employment, she'll have to wait until the next open enrollment period to join. If she joins later, there will be an elimination period. She'll have to wait a specified period before any pre-existing health conditions are covered. The policy requires her to pay part of the cost for most healthcare services, and some procedures, such as cosmetic surgery, aren't covered. This scenario raises important questions. Why are group policies less expensive than individual policies? What's the purpose of open enrollment and elimination periods? Why are patients required to pay part of healthcare costs? And why are some procedures not covered? Private health insurance and managed care represent complex systems designed to balance access, quality, and cost in healthcare delivery. The evolution from simple indemnity insurance to sophisticated managed care organizations reflects ongoing efforts to control costs while maintaining quality care. Understanding these systems is crucial for healthcare professionals who must navigate insurance requirements, prior authorizations, formularies, and network restrictions in their daily practice. The uninsured population remains a significant challenge, highlighting gaps in our current system. As healthcare costs continue to rise and new technologies emerge, we can expect continued evolution in insurance structures and managed care approaches. The key is finding the right balance between controlling costs, ensuring access, and maintaining quality of care. Today, we've explored the complex world of private health insurance and managed care, from its historical origins to current challenges with the uninsured population. We've examined how different managed care models attempt to balance the competing interests of patients, providers, employers, and insurers. As future healthcare professionals, understanding these systems will be essential to your practice. Whether you're working within an HMO, negotiating with a PPO, or helping uninsured patients access care, this knowledge will help you better serve your patients and navigate the healthcare system effectively.